And welcome to this special live broadcast of The Dental Guys. I'm Wes, the Dental Guy.
And I'm John, the Dental Guy. And this is the day 2 of Star of the North. And this has been a great meeting.
Yeah.
I mean,
I'm actually surprised.
I know. I knew it would be good, but I didn't know that the turnout would be as much as it's been. The exhibit hall is like hopping.
Even last night, if you weren't here at about 5 o'clock, dude.
Yeah, we're doing an interview.
Yes.
And then it's 5 o'clock-ish. And no, it was like 4:59. Yeah. And at exactly 5 o'clock.
Our sound guy, Steve, over here. Shout out to Steve because he put some gates on there. I don't know.
Well, exactly 5 o'clock, the DJ pumps up the volume. I mean, pump it up. And it's like cocktail hour has begun.
Right.
And it's just like a party going on over there. And, you know, everybody comes down, and so here we are, and it's just some awesome energy.
Have you ever been to a meeting where, you know, they had like a cocktail hour in an exhibition hall amongst other, you know, all the vendors and stuff?
Not quite like this.
I think the only time was at the International Dental Show in Germany, where it was like a party, like amongst all the vendors.
Yeah.
It was amazing. It was an amazing vibe here last night. And if you didn't come this year, I encourage you. They've got amazing speakers here.
Yeah.
And so I'm glad to be, you know, bringing you guys live, you know, from Star of the North Dental Meeting in St. Paul, Minnesota. Right? Here we are.
Exactly.
It's not winter, but
That's
it feels a little cooler.
It's a little chillier than what we're used to, right?
But, John, tell us about our guest today.
Yeah, well, we've got a good one for you folks out there because, you know, it's what we've loved about this is we've gotten to interview people from completely different backgrounds, from clinical dentistry, dental hygiene, and we're going to be talking to somebody who's got a very interesting background, Dr. Juan Yepes. Thank you for joining us today.
I love to be here. Love it.
Yeah.
I love how you pronounce Minnesota. You know, with my Kentucky accent, sounds really cool. Minnesota. You can tell. Love it.
Yeah, thank you.
You told us a little bit about your background.
I cannot do that. So don't ask me. Minnesota. I need to tell Minnesota.
Hey, that's pretty good.
You know, with my Kentucky accent, I barely can say Minnesota. I will tell you in a few minutes. I have a few words that if I pronounce with my accent, they sound really bad.
Yeah.
So remind me later.
At the end of the show,
stay tuned for that.
One word that you need to leave it at the end of the show. Otherwise, everybody will say, "Okay, that's it."
That's right. Because
all right.
hey, we're going to be talking about pediatric dentistry today.
Yes.
We're also going to be talking about radiation. In particular, I'm interested, John, in talking a little bit about exposure for our youth.
Yeah.
Right?
Yeah.
And
how do we reduce exposure?
I mean, I'm building an office. I mean, you still have to buy, you know, the stuff to expose patients to radiation.
Mm-hmm.
We have digital sensors today. All that stuff's been updated. What's changed, right? What do we know more about, like these portable devices, things like that?
Yeah, and I think that before we get into the actual meat of the topic, talk a little bit about you. For those who don't know who you are, talk about, you gave me a little bit of the story of your life, but you know, tell us where you are, what you do, what your interests in research and things are.
Okay, that's nice. Okay, first of all, thank you for the invitation. I really was waiting for this for the last 20 years, so finally you invite me to do this.
Yeah.
So my name is Juan Yepes. I'm a full professor at Indiana University. I'm an attending at Riley Children's Hospital, which is the Indianapolis Children's Hospital. This is my year number 8 in Indiana. I'm a pediatric dentist, and before becoming a pediatric dentist, which is not too long ago, actually I graduated from Pedo in 2012. I was the director of radiology at the University of Kentucky, and I did oral medicine, so really my background is mixed. And then when I became a pediatric dentist, pretty much what I did is I took my background before doing pedo in radiology and oral medicine, and I put it in the context of working with the kids. So I became very interested about radiation safety in kids. And obviously, as a radiologist, as a pediatric dentist, I'm a practitioner, and I see patients. I use radiation. In fact, if I see X-rays walking outside, I will run and give a kiss. I love X-rays because sometimes it's the idea that if you are you belong to the group of radiation safety group, sometimes you will get the misperception that I'm against X-rays, and I'm not.
Yeah.
Actually, I love it. So my research is in radiation safety, in dental materials, and obviously in a bunch of different issues with medically compromised children. And so that's what I do for a living. And this is my year number 8 in Indiana. So I'm also a private practitioner, so I have a private practice. So that's a good way to combine teaching and being around the residents and really try to keep very updated my background. But also, I struggle like you in real life dentistry. And it's easy for me to say, for example, oh my God, we all need to switch to rectangular collimators because it's probably the best way to save radiation. But I know when you go to private practice, you may well get a bunch of concats, and then in real life, when you have a 5-year-old, which is not really very happy to have something in the mouth, then it's maybe challenge. So, you know, that one foot in the hospital and one foot in private practice really helped me to understand both sides and try to come with a common agreement between what is the best way.
Yeah, so you're used to dealing with all the issues from managing the patient in a private practice as well as managing teams and things like that. And I think that's fantastic. But for students, that allows you to actually maybe have a little special touch that with that education.
It adds a little bit of believability when you talk to a student or a resident where you say, look, I do this, so I understand that the reality is sometimes different than what we read in the textbook, but we still have to pay attention to the textbook. And let's dive into that. You know, talk about what are some of the biggest issues today in radiation safety, especially for our pediatric patients. What are some things that you're seeing that maybe we're not doing well, or things we should be changing, or maybe some things we are doing well?
Okay, I love it. Love the question. So here we go. The collimation is probably one of the issues. As you probably know, we're supposed to be using rectangular collimators. I think that's one of the main issues. If you look at the history of radiology, oral radiology, rectangular collimators was the way to go years ago, and then we switched to round collimators. And now, obviously, we understand that we want rectangular collimators, but less than 5% of the dentists in the US, they use rectangular collimators. That's one issue. The second issue is the perception that if I have digital radiology, I'm using 99% less radiation. And this is a misperception, because sometimes, you know, some practitioners, they will say, oh my God, I'm using digital radiology in my office, so I am operating in a perfect radiation safety environment. And sometimes it's not true. Because what happened with digital radiology is the easy retakes. And few dentists that really account for the number of retakes. You know, with digital radiology, you know, it's pretty easy to take the decision, you know, let me take one more projection. In the old days, you guys are too young, but in the old days, when I was a dental student years ago, a retake was a pain, and I really, believe me, going back to the patient and smiling and say, hey, by the way, we need to take a new one. So rectangular collimators, digital radiology, and finally, I think so the one more issue in these days is related with the use of handheld X-ray devices. You know, it's always the question, if I use that, I'm going to kill my assistant just because she's getting a lot of radiation. So that's a question that it comes in especially in pediatric dentistry, we use this Nomad or X-ray to go. Obviously, I'm not here by supporting any brand name, but sometimes we refer to the things by the brand name.
Yeah.
And so that will be the three issues in radiation in kids.
Yeah, I think we come back to why are we not using rectangular collimators?
What happened with the, you know, I have been asking that question to myself for, you know, the last 10 years. I think so part of the problem is if you take a radiograph, you must use the XCP. You know, different places, the XCP is the X-ray positional device.
Yep.
So some dentists, they take radiographs using round collimators and they don't use the XCP. Now, if you switch to rectangular collimator, you must use the XCP because otherwise you are going to get a bunch of concats. But, you know, believe me, using rectangular collimators, you save about 60% of the radiation. So the decrease in the radiation to the patient is significant, very significant. So what I tell, you know, when I lecture in radiation safety, like tomorrow, you know, it's almost like a joke, but if you are going to move into rectangular collimators, and I invite everybody to really seriously think about that, you need to invite all your staff 1 week, all paid to Cancun. And then the last day of the trip, you need to tell your staff, by the way, next Monday we are moving to rectangular collimators, otherwise they may well kill you.
I like this guy.
So what happened is, you know, moving into rectangular collimation requires, you need to pay attention. You need to use the XCP to really align the film or the sensor with the tube. If you, like sometimes I see that if you take the radiograph while you are talking and chatting with the parents or whatever, if you switch to rectangular collimators, actually at the end is worse because you may end up with more retakes. And remember, a healthy dental practice, so a practice who is doing dentistry in the perfect range, you're supposed to don't retake more than 15% of your radiographs.
Okay.
And if you don't really account for the retakes, you don't know. And if you switch without going to Cancun, could be also Puerto Vallarta. You know?
Yeah.
Those
Could
are
be-
your two choices.
Could be also Jamaica, a couple of
Okay.
options. But you need to include everything for every single staff member. Otherwise, if you kind of select someone, they will kill you.
This is going on record.
I hope that
This is now we have to spend even more money.
Right.
Right.
So
But I hear, but you have to do something, because if not, like you say, talk about that in the pediatric population, because the hardest place to use that is in a child that is moving, who doesn't want you to use any type of collimator or even be in the practice.
That's
so
right.
so how do you feel that you can reduce the retakes enough with rectangular collimation that you can essentially, how many retakes can you do on a 5-year-old before you're just not going to get an x-ray? Is it worth it? Is it worth it?
Absolutely. Now, you need to also, in the whole concept of X-rays in children, you need to also include that probably the best way to go is with a hybrid system. In other words, some dentists, they love the sensors. Some dentists, they love the phosphoro plates. I'm in between, really, honestly, in between. And I teach dental radiology for 10 years. And I used to be, and absolutely convinced that sensor was the way to go, or direct radiology. But now as a pediatric dentist, and everybody listen, that you are a dentist, that you see kids, you don't need to be a pediatric dentist. If you work in both sides, if you have the ability to take some patients or use in some patients phosphoro plates, and in some patients sensors, you are going to decrease the retakes. Because there is no question that if you have a 2 or 3 year old kid with a small mouth, if you try to place even the smaller sensor, is challenge.
Yes.
People can tell me a million times, oh, I develop a technique in my office to put it is, in real life, is challenge. Now, phosphoro plates are perfect for little kids. Now, when you have an older kid, more cooperative, that can understand what are you going to do, then you can switch to sensors. So hybrid systems, rectangular collimators, and always collimation, always protection of the thyroid.
So I want to ask you this, is that with the current x-ray systems in our office, if we're using round collimators, how easy is it to switch to a rectangular collimator?
I'm going to avoid to cry, because that question really breaks my heart. So, in the good way, I love it. You can retrofit your system. You can buy, there are adapters that you can just place it in the round collimator, and then you can convert your round collimation system, which is what I have in my office. And if you go around here, you will see that they are round collimators, and you can move a round collimator into a rectangular collimator without buying a new X-ray equipment.
That's good news.
You can just buy that. Obviously, Cancun need to be in between.
Right. Yeah, that's the recurring theme. So when you talk, you mentioned thyroid protection. It's a
good.
perfect segue into talking about what do we actually cover patients with. I remember a few years ago, I read an article about, putting patients in, the Panoramic machine, and that we maybe didn't need to be putting a drape over a patient, but the thyroid collar keeps coming back. Talk about, how important are lead aprons? How important are thyroid collars? What really matters with that?
Well, you are really touching base in something that is really, really, really at the top of the news in radiation in these days. The use of lead aprons is really under reevaluation. In fact, there is now good evidence, and is supported by the major radiation organizations in our country, that the use of lead aprons is probably not necessary. In fact, could be actually bad. What happened is, when you use the whole lead apron, some X-rays, we call scatter radiation, can go out and bounce back from the lead apron back to the patient, back to the lead apron, back to the patient. So we really, honestly, we don't need to use lead aprons. We need to protect the thyroid, but we don't need to use lead aprons. The problem is public perception. It will take years before, the parents of my patients, they really understand that the whole protection is maybe not necessary, because they have the mindset that if the dentist is going to take an X-ray, they need to protect that. So if you want to spend 20 minutes for each family going through all the evidence and everything, that's fine. But if not, it's going. Now, the point about the panoramic films and the thyroid, if you place a thyroid collar and you do a panoramic film, obviously you are going to obscure sometimes the whole inferior border of the mandible, and you may actually obscure more than that. So, obviously you want to have the whole area that you want to evaluate. My concern is, and this probably is for a different conversation with you, with both of you, but in lateral ceph, the one that ortho uses for cephalometric analysis, we don't protect the thyroid, but we can protect the thyroid, because when you protect the thyroid in a lateral ceph, you may well cover the cervical spine. But how many orthodontists are still using the cervical spine to look at the patient chronological age? Very few. So
let me ask you this, is that a lot of our orthodontists are employing cone beam technology. And we are using cone beam technology to measure palatal sutures, things like that, for growth and development. We're moving into an age where, too, some of the machines that we're using, even our ENTs in hospital settings, are buying dental grade machines, dental CTs, because they are such less radiation and less costly. What is your opinion on radiation safety in children within cone beam?
okay, so there is a lot of misconceptions about cone beam CT. My first statement is I love cone beam CT. In the same way that if I see an X-ray, I will go and give a kiss and have a date. If I see a cone beam CT walking around, I will do the same. So that's my opening statement. The second point is there is a lot of, people have the tendency to minimize the radiation from cone beam CT to almost nothing because you are comparing with CT. So when you compare cone beam CT with CT, there is no question there is less radiation. But you need to be careful because when you compare cone beam CT in terms of radiation, you need to understand the field of view that you are using, because you may actually are putting together apples with bananas. And let me explain that. A cone beam CT full volume, the radiation is completely different than a cone beam CT limited view. So the point is the technology is there, and in kids, for example, we need to understand that in some situations, cone beam CT is a wonderful tool. No question about that. Impacted canines, if you want to localize the inferior alveolar canine in case of pathology. So there are clear indications of the use of the technology, no question. However, in terms of radiation, we need to be careful. A cone beam CT full view, which covers maxilla and mandible and the temporomandibular joints. I'm sorry, I love to do this. So sorry, everybody, I'm touching that, but I'm still good here. I hope it's still good.
Pull it back up.
Pull back up.
There
Love it.
There it is.
So a full cone beam CT, in terms of background radiation, is about, I would say, probably 13 to 15 days of background radiation. A full volume cone beam CT. One panoramic film is about 1 to 3 days of background radiation. One lateral ceph is about 1 day of background radiation. So if you compare in terms of radiation, if you have an average patient who is coming to the ortho office for a, average ortho treatment, and you are just doing cone beam CT, full volume, rather than one panoramic film and one lateral ceph, you are giving more radiation to the patient. Now, you don't smell the radiation, you don't feel the radiation. The evidence in terms of what will happen to me as a patient is difficult because you need to isolate the radiation coming from the cone beam CT from other forms of radiation is challenge. Plus the problems will happen years after the cone beam CT or the dental radiology, so it's difficult to make the connection. So to kind of close, this is a very interesting area, a lot of discussion. There is always the point if the cone beam CT technology is making the outcomes better in terms of doing the ortho treatment quicker or do it in a way that is much better than using the traditional radiology technology. So that's one more factor that will be in favor of cone beam CT, but the evidence is not in that direction. I think so in some situations in kids, if you have a kid with a syndrome, if you have a kid with an impacted canine, if you have a kid with a supernumerary, if you have a kid with a radiolucency that, is maybe an ameloblastic fibroma. Do you remember the ameloblastic fibromas?
I remember it well. I really do.
You remember that? Do you remember the
Yes.
ameloblastic fibromas? Okay.
Yeah,
Okay.
that and the OKC.
The OK, I was going to say there's a differential diagnosis. OKC is always in there.
OKC.
Or ameloblastoma. I tell my
Right.
students that every time that they see something unusual in a radiograph,
Ameloblastoma, OKC.
ameloblastoma.
Yeah.
It's like a sweet word for the brain.
It really is.
It really
is.
is. We
and
love to say
and it's fun to say.
The name of my dog is ameloblastoma.
Oh my
No, really.
gosh, I love this.
when
This is awesome.
When I take my dog to the veterinary, And with my accent, I tell the doctor, you need to focus in my ameloblastoma. So the focus with the ameloblastoma really sounds, we Latino with I cannot say focus in the way that you say focus.
But you can get away with it anytime
Right.
you want.
Well, that's one of the words right there we're waiting on.
That's right.
So let me ask you another question. As we move into restorative, let's talk a little bit about pulpotomies and pulpectomies, and what are we doing to the top of the tooth? You have we do have pediatric practices inside of our practice. One way to grow a general dentist practice, and you're going to run into situations where these are necessary. One, what's the most modern techniques? What's the research saying about how we should be doing them? Number two is, as a follow-up, is it okay not to do a stainless steel crown or some type of full coverage restoration after a pulpotomy is done?
Okay. I will invite everybody. My afternoon talk today is about dental materials. So I will cover extensively materials for pulpotomies. But just to answer your question, I answer the second question first. There is no question, and the evidence is in that direction, that when you perform a pulpotomy or pulpectomy in a primary tooth, you need to provide a full coverage. No question about that. And we see a lot of failures when dentists, when they go ahead in a primary tooth, K, T, L, or whatever, and you do a pulpotomy, and then you decide not to put a full coverage, you just do an MOD amalgam or MOD composite. There is a lot more susceptibility for failure than when you do a full cap. Now, we back up this with, we published an article about 5 or 6 years ago in the Journal of the American Dental Association when we compare caps after pulpotomy and MODs after pulpotomy. It really shows in terms of surveillance, in terms of which one will stay longer when you place a cap. Now, going back to the first question about pulpotomies, I think so the technique is still the same. The indications are still the same. And so we understand when a pulpotomy is indicated, we understand when a pulpotomy is indicated, and more important, we understand when the pulpotomy is contraindicated and when the pulpectomy is contraindicated. I think so when we have new, which is not really something from yesterday, is we have new materials who save us steps when we are doing the pulpotomy. Because in the old days, when we used to, not anymore, but in the old days we used formocresol, you probably remember that. So in the old days we used to, open the pulp chamber and then just place formocresol, wait 5 minutes, and then after that we'll fill the pulp chamber with ZOE or IRM or whatever, and then we place the crown. But in these days with the new materials who are highly biocompatible, you can place the material in contact with the pulp horns when you do the pulpotomy, fill with that material the pulp chamber, and then place your crown. So we are skipping one step. And in pediatric dentistry, at the end, everything that helps us to do the things quicker is good for us. Usually the kid will be happy for about 5 minutes, and then if you take more time, then you are in trouble. Some of these materials are what we call in these days Dentin Substitutes.
Yes.
And we have MTA, or Portland cement, which is not really a new material, has been around us for a long time, but just recently becoming a very helpful material for pulpotomies. Or biodentin, which is also one of the dentin substitutes that you can just prepare any of this material. So you open the pulp chamber, you remove the pulp in the pulp chamber, you see the pulp in both roots, and then you place the material in contact with that, and then you place your crown.
Yes, and that's changed the way that we do it, like you say, from a material standpoint. But everything else has kind of remained the same. And I think it's good to have that kind of definitively said as far as how the need for the full coverage restoration. Which material do you typically prefer? We have a lot of discussion about MTA and biodentin. Are they equivalent in terms of their success?
I have one foot in the hospital in a teaching program, and I have one foot in a private practice. So sometimes, at the teaching level, we have some restrictions in terms of what materials we can use. Sometimes the hospital will have some restrictions. So the program itself will say, we don't have not the budget, but we are not going to buy MTA or biodentin. So, but honestly, both materials are excellent, MTA and biodentin. With MTA, we used to have an issue in terms of mixing.
Yes.
It takes some time to mix, and you need to you don't need to take your assistants to Cancun, but it takes some time to mix it. But in these days, we have pre-mixed MTA.
Yes.
On the other side, biodentin comes in capsules, so you just mix with a few drops of water, and then you put that in an amalgamator, and then you just open the capsule and you take the material from the capsule to the cavity. Both materials are very similar in terms of biocompatibility, antimicrobial effect. I think so MTA is more radiopaque, if that cares. I mean, if that helps you when you are looking at the radiograph, the biodentin. Setting time is clearly different. MTA will take longer. Biodentin is a shorter setting time. I think so my recommendation, and I tell this to my residents and my colleagues, if you decide to use MTA or biodentin, which they are materials that, in these days, you pay for that.
Yes.
You need to work smart in the way that you need to, the perfect patient will the patient that you need a couple of pulpotomies, because sometimes what happens is when you open the capsule of biodentin and you only have one tooth, then you are going to end up to wasting half of the capsule. So in that situation, I probably will use a pre-mixed MTA. But if I have a patient that I need 2 or 3 pulpotomies, then I can just mix one capsule. It will be plenty of biodentin for these 3 pulpotomies. Now, both materials can also be used for direct pulp caps for trauma cases.
Yes.
Or trauma patients. I don't like to say cases, patients. So direct pulp caps, both materials, they work perfect. Endodontists, they also use both materials for repair, perforations, and a bunch of different things.
You know, I think as far as like, I want to kind of switch up gears again to the business of pediatric dentistry. In the specialist realm, it seems like that we're seeing a lot of pediatric dentists hire general dentists. And we're seeing them kind of curb their procedures to, birth until 5, 6. And I'm not, I'm saying like then we're going to move in from the 7 to 13-year-olds to keep the patient in the practice. There's a general dentist there doing general dentist things on, adolescents, youth, things like that. What's changing from a standpoint of pediatric dentistry in the business realm? I know you're a practice owner and yourself, right?
Yeah, I own 3 practices, and I wouldn't know anymore, but just recently I have a general dentist working in the office.
Yes.
I think so what happened is, number one, to hire a pediatric dentist these days is very challenging. We don't have too many pediatric dentists available. Even for me as a faculty in a residency program, usually the residents, when they start the residency program, they already know where they are going. So it's extremely difficult to hire pediatric dentists. And in these days, the market is becoming very competitive in terms of benefits, salary, and everything else. So I think so many pediatric practices, the way that we are moving now in order to survive is we want general dentists, which I prefer to say family dentists, and we want family dentists who will take care of the teenagers. That sometimes, the dentistry, obviously, we pediatric dentists, sometimes we believe that our dentistry is not too complicated. It's more the behavior of the patient. So we can concentrate, I didn't say focus, we can concentrate in the young ones, in the little ones, who they require more training in terms of behavior management. And then the family dentists will take care of the teenagers. I have a lot of respect for family dentists who work with teenagers. Teenagers, they sometimes are as difficult as working with kids. They may not move or they may not cry, some, but in terms of really engaging the patient with the practice, it's extremely challenging. It's very challenging. They, in terms of hygiene, in terms of, flossing and really understanding that drinking, one of these sodas all day long is going to cause problems. It's very challenging to really make a difference. So I think so the new model of the pedo practices is the pediatric dentist will take care of the little ones, and many of these patients you need to go to a hospital or ambulatory center. And then the family dentist, which is a member of the team, will be the one who will be taking care of the teenagers, so the older patients.
Are you seeing sedation being done in office much anymore, or is that pretty much all moved into the hospital setting?
You are touching in something very painful, very painful. COVID, which is the first time that we mentioned COVID, which I love it, because we need to start to, we acknowledge the COVID, but COVID really changed the access of pediatric dentists to ORs. So in these days, I will tell you, some pediatric dentists, the opportunity to go to the OR is almost a year ahead.
Wow.
Can you imagine as a parent, if you go and your kid has 4 quarters of dentistry and you tell the parent you need to wait a year before we can fix it, it will be a completely different patient. So I think so more and more and more we are using, which is amazing good. I cannot tell you, dental anesthesiologists are a blessing. In the state of Indiana, which is my home now, we have 2. So imagine for the whole state. And I work with Juan. He comes to my office weekly. In my office, I have a sedation suite, which is about 500 square feet. And he comes weekly, and we take care of the patients. Dental anesthesiologists are a wonderful resource. But again, the problem is we don't have enough dental anesthesiologists, at least in Indiana. The majority are located more in the West Coast.
Right.
Okay.
But they are, they are dentists. They are extremely well qualified. As you know, dental anesthesiologists is a 3-year residency program, which out of the 3 years, they spend up to 2 years working as an anesthesiologist.
Yes.
They work in a high, safe environment, and they understand our needs. We can communicate each other. They look and say, "Oh, I see teeth," and it's a wonderful relation. But we need more. We really need more.
So this idea of ambulatory care or outpatient surgery in a pediatric office that's owned by a dentist, and then you hire contract to an anesthesiologist, you call him a dental anesthesiologist, is this here to stay, and will universities that are attached to hospital situations be the only people that are actually going to the hospital to have procedures done?
No, I think so. This is going to stay, and I think so more and more in the way that the more residency programs in dental anesthesiology opens, we are going to have a more human resource in dental anesthesiology. I think this is the way to go. Now, some patients, with medical issues and patients with some complexities, they are still going to the hospitals. And obviously,
Sure.
when you have medical problems, but I think so the future, looking 5 years from now, 10 years from now, is the majority of patients, the ASA1, no medically compromised, healthy kids, they probably will go into ambulatory dental offices like my office or ambulatory surgical centers. I think so that's the future.
So you're going to see a lot of people building on, I would guess, to their offices or building new office with surgery suites or anesthesia suites having to be kind of a necessity because, like you say, you can't wait a year. So I think if there are people listening to this who are trying to decide on kind of where they need to take their dental career, that's something to look at. Dental anesthesiology. I mean, I think that a lot of my friends that I know that are CRNAs are very happy with that practice model as well. It's not only super helpful to the patient, especially relieves a lot of this demand, but it's also it's a pretty interesting job.
Yeah, dental anesthesiology was recognized by the American Dental Association as a specialty not too long ago. They have been around dentistry for a long time. Now that they are officially recognized, I think so. I hope, cross the fingers, that we are going to see more and more dental students interested in dental anesthesiology because there is an amazing room for dental anesthesiologists. I have 2 IU students that recently they came to me and say, we are applying to dental anesthesiology. Big hug and how I can help you, how I can, I will add something. I know we are running out of time, but you can get accreditation when you have a sedation suite in the dental office. There are at least 3 or 4 national entities that they will come to your dental office if you have a sedation suite, and they will look at the safe. They are a huge checklist.
Like JACO or something.
Like JACO,
yes.
and that's one of the, and they come to your office. It's expensive, that step, but that will actually give you an amazing 3 stars to or 4 stars or 5 stars to your practice, because that means that you are operating under a perfect safe and security, and I think so that must be always the frame when you do dental anesthesia, because we basically in my office we do general anesthesia.
Yes.
That's right.
And
you're intubating.
And the patient is fully intubated.
Yes.
It's
We're not just
airway.
talking about oral conscious sedation here. We're talking about intubation. And I think that's fantastic because, I was in a GPR for an entire year at UT Medical Center. And, man, it is booked. It is booked, and I'm a faculty member there, and it is booked solid for 2 years. If we have a patient show up for surgery, well, I'll see you. And like you said, that's a different patient 2 years from now.
Right.
Yeah.
And what's really the access to care for this, I like what we're doing here, is that, one, we've created a subspecialty in dentistry, which we've needed for a very long time, a dental anesthesiologist. And then on top of that, we're increasing the access to care. And I like the idea that pediatric dentists are focusing on what they're best at. Right, which is management of that very young patient.
Absolutely.
Right, and then the family dentist comes in, maybe a clinician that needs to come out of school and immediately start to work, well, there's a need in pedo offices.
Right.
And so I think it's a great opportunity.
Yeah.
I will tell you, and just one sentence. We didn't touch base about something that maybe will be a nice topic for a conversation, which is special needs patients. Special needs is a huge population of patients that unfortunately, they are almost feeling like orphans. It's difficult for the parents to find dentists when they reach 18 and older. So the dental anesthesiologists, together with pediatric dentists and together with general dentists or family dentists with expertise in GPR, are also a perfect, group to provide care to these patients who is extremely challenged.
That's right.
Extremely challenged.
Yeah.
Oh, yes, absolutely. Yeah, we need to have that discussion one of these days.
We need to have that discussion.
Yeah.
And I think now that we've met each other, I think for maybe a future show, we look at talking about growth and development.
Yep.
Right? I think that's a hot topic right now, and how early is too early to intervene. Myofunctional therapy, these are all things that John and I love and are passionate about.
Yeah.
And so, man, it's been a great conversation.
It has. And I guess the last thing I have to ask before we leave is, I need to know these words.
Yeah.
Because
well, I just one. Do you want me to tell you again to focus in your podcast?
yes, I'm going to record
What is
that.
funny is my daughter, she keep telling me, Dad, you just say fuck you. You need to kind of cues looking at the mirror, but it's always a challenge, And the other thing is, so focus is one, and the other thing is when you have an accent, there is only one place in this country that you can never go. That's a question for you. Where do you think you never, ever can even try to go when you have an accent? And for everybody who will listen to this, think about it. If you are trying to learn Spanish or Portuguese or French or whatever, what is the only place that if you have an accent you cannot go? Easy. Any drive-through.
Love it, man.
It's the most frustrating. You can. I living in this country, which is now my country, and I became citizen of this beautiful country. I can still not, when I'm, hey, let's go to the drive-through. I can't. Because whatever I say to the microphone, they never get it.
I wish I was like 5 or 6 years old and I needed a filling and I could maintain my cognition as an adult. I'd like for him to give me an injection.
I know. I'd like to come to your office.
Just sit there and let him do
watch
something.
I will tell you
what you do.
I always, last night I was walking in the park with my dog and I saw a deer.
Ameloblastoma.
And then this is when I'm ready to inject the kid. And I said, the deer look at me and say, hi, I'm the deer. And then the deer tell me, Dr. J, I'm super hungry. Meanwhile, and then the deer always say, okay, can you take me to McDonald's? I tell the story 20 times a day about the deer going to McDonald's.
How your assistant's like,
oh my God, at the end of the day, they say, please, no more deer. So I substitute with penguins and different things.
I love it, man.
Well, thank you for being with us.
You're welcome.
It's been a lot of fun, a lot of great information, and I think that if you listen to this, you want to hear more from Dr. J, as he said. Let us know if you want us to have him back, back on the show. I think it would be awesome to do that. And if you are enjoying what's coming, again, we have some more. We have David Clark coming up, kind of a big deal later on today, talking about BioClear and composite. We're super excited about that. The hits just keep on coming.
Yep.
It's been a great meeting. Let us know what you think on all the social media outlets. Of course, hit us up, give us some feedback, send us any questions you have for our guests. And I'm going to go ahead and close this out because we've got more to do, more coming. So for Dr. J,
Thank
for
you.
Wes, I'm John, and we are the Dental Guys.
Thank you so much.